companies and laboratories. I'm here just to raise the level of what RGCC stands for and what is the actual purpose of all group of laboratories and companies on serving cancer patients. We try first to help cancer patients and doctors at the present time, and we try also to help cancer patients in the future. That means we are offering testing and screening for cancer patients in order to have tailor-made therapies, and as well we are working intensively in the back end on drug development and discovery in order to develop novel therapeutic approach for cancer patients in the future.
Untuk pasien kanker, seiring waktu dipenuhi rasa takut dan ketidakpastian. Bahkan setelah memulai pengobatan, beragam pertanyaan tetap ada. Apakah terapi ini berhasil? Apakah kanker sudah menyebar? Apakah kanker benar-benar terkendali? Terkadang pemeriksaan dan tes rutin gagal mendeteksi bahwa kanker masih ada atau pengobatannya belum maksimal, menyebabkan pasien dan keluarga tetap berada dalam kekhawatiran dan tidak dapat melihat situasi dengan jelas. Sekarang, bayangkan sebuah masa depan di mana Anda tidak perlu menunggu dengan rasa takut, bertanya-tanya apakah pengobatan kanker Anda berhasil. Dan dengan tes darah sederhana, Anda memiliki kesempatan untuk melihat tidak hanya jumlah sel kanker di tubuh Anda, tetapi apakah sel-sel itu masih menjadi ancaman. Memperkenalkan OncoTrace, tes revolusioner kami, yang membantu mengatasi tantangan ini secara presisi dan personal. Menyediakan kejelasan kepada pasien dan dokter untuk membuat keputusan. Kanker dimulai di sel-sel kita. Ketika sel sehat bermutasi atau rusak, mereka berkembang biak terlalu cepat dan membentuk benjolan yang dikenal sebagai tumor. Seiring perkembangan penyakit, beberapa sel terlepas dari tumor dan masuk ke aliran darah menjadi sel tumor yang bersirkulasi atau circulating tumor cells. Jumlah CTC menggambarkan sel kanker yang beredar dalam darah adalah indikator penting dari progres pengobatan kanker. Namun, untuk benar-benar memahami situasinya, penting untuk melihat lebih dari sekedar angka. OncoTrace meningkatkan pemahaman ini dengan menganalisis tidak hanya kuantitas sel kanker, tetapi juga karakteristik spesifik melalui penanda phenotype dan penanda stemness. Menawarkan pandangan yang lebih komprehensif dan personal, tes ini memberikan informasi berikut: jumlah CTC, penanda phenotype, penanda stemness untuk membantu klinisi membuat keputusan. Jumlah CTC, ini adalah ukuran jumlah konsentrasi sel kanker yang beredar dalam tubuh. Peningkatan konsentrasi CTC mungkin menunjukkan bahwa pengobatan tidak sepenuhnya efektif, sementara penurunan dapat mengindikasikan keberhasilan. Penanda phenotype, penanda-penanda ini mengungkapkan sifat-sifat melalui protein pada permukaan sel. Penanda ini membantu menentukan asal kanker, karakteristiknya, dan bagaimana kanker tersebut dapat berperilaku. Informasi penting ini sangat membantu dalam menangani kasus kompleks yang melibatkan beberapa tumor atau metastasis. Penanda stemness adalah protein yang menunjukkan sifat seperti sel punca pada sel kanker. Penanda ini mengungkapkan seberapa agresif kanker itu, serta kemungkinan kanker untuk tumbuh, menyebar, atau kambuh. Tingkat presisi tes ini memungkinkan penanganan Anda tetap selangkah lebih maju dari penyakit ini. Tanpa analisis terperinci, keputusan mungkin diambil berdasarkan informasi yang tidak lengkap yang berpotensi menghambat pemulihan. OncoTrace melengkapi informasi dan menawarkan pandangan yang komprehensif dan personal tentang kondisi kanker. Ketika Anda memahami kanker Anda lebih dalam, Anda tidak hanya menebak. Anda membuat pilihan berdasarkan informasi yang dipandu oleh data penyakit Anda secara khusus, sehingga dapat memantau perkembangan penyakit untuk mengatasinya. Dengan OncoTrace, Anda tidak hanya melacak kanker Anda membuka jalan menuju pemulihan secara presisi dan personal. Pilih RGCC untuk solusi kanker yang presisi dan personal.
Dr. Papasoteriou. I am the director of RGCC International from Switzerland. We're here in the US to complete the summit of 2019, which is taking place annually. This year we try to bring a little bit of more knowledge about liquid biopsy, cancer diagnostic, and bridging genetics and oncology under one roof. We try to bring every new technology and therapeutic option about cancer patients as well as to other disease and how the new inventions on technology help patients on these two kind of diseases. I hope that the clinicians will comply and they will enjoy the training as well as they will get a lot of hands-on training on practical issues, hoping to harmonize all clinicians around the world and improve the quality of clinical service, mainly in oncology. Most of the attendees are practitioners and clinicians, which they are treating mainly cancer patients as well as chronic disease. Their main goal is to increase their knowledge about the diagnostic as well as the treatment options about cancer, as well as to get training, practical training of how they should apply therapies, what kind of pre-medication they should get, what kind of adverse reactions they will expect or possible side effects, how they may counteract on them, so that they will not sail in dark waters. So our main goal is to, again, to improve their skills so that the patient will get the final benefit. Mainly, they are clients of ours, and we try to harmonize the clinical practice which they are offering based on our diagnostic. So this requires that we need to bring the training to them. So that's why we jump the Atlantic and we're here just to bring them on the same level that is required, because patients are existing everywhere and they should get the same high quality of service anywhere in the planet. Well, RGCC is about innovation. This is what is the main concept of RGCC Group. We have not only one place of laboratories, but at least 3, and we're growing. Our main goal is to create new therapeutic options. So not only the diagnostic, but as well as to offer better treatment for mainly for cancer patients. So we offer the diagnostic in order to gain more data so that drug discovery will take place. So our main field is our drug discovery and drug development. So we take all the database and all the knowledge and all the DNA and RNA profile from each patient suffering from different type of cancer, and we identify new druggable targets. Then the drug development is taking place. So we already have our pipelines with new molecules which may be candidate drugs for near future for cancer patients. Yes, but similar weights and similar molecules do exist on late stage. But we are equally involved in that field. We have also novel targets, which are in very early stage. Hopefully that we will manage to bring them to even to the late stage of approval. But our main goal is that the more option you create for cancer, the better it is, and more close steps you do towards the actual cure of the disease. Practically, what makes difference on RGC compared to what other laboratories are offering is that we are working mainly on what is called liquid biopsy. So practically we identify this tiny population of cells or tiny molecules of DNA fragments which they are spread from the tumor, and actually they can cause the disease progression. And all of us know that the cancer is actually one of the major disease that actually leads to terminal stage of patients. And they are reaching that point due to the metastasis and the disease progression. The disease is highly heterogenic,
So many times we base all our approach based on the data that we harvest from the primary sample, but when the disease is already systemic, we don't have the necessary tools to deal with it. So since we are working with a common link which actually connects the metastatic point and the primary and vice versa, we have more accurate knowledge of how the disease is progressing and how the disease is moving forward. So we identify repeatable patterns as they are known on their genome or their gene expression, and this is how we actually we discover targets. We validate these targets with specific techniques in genetics, and this is how we conclude that this target is actually worth to block. And this is how the drug development is starting. So what makes us unique is under one roof, we offer diagnostic therapeutic options, new therapeutic options on development, and new drugs under one concept. And since our main goal is, we need to find the holy grail of cancer, how we should treat these diseases, because it's not one, it's thousands of them. The clientele of RGCC could be on let's say, two major fields. The one is private practitioners, which they deal with cancer patients, which they could send samples, and these samples are analyzed, and we send back the profile of the liquid biopsy of the circulating tumor cells from the genome perspective, from the genome expression perspective, and how sensitive or resistant are to the treatment options that exist nowadays. The other part are the university hospitals and the pharmaceutical industry, which we actually offer that as a service in order to find and develop new therapeutic molecules, new candidate drugs. So this is our present clientele of RGCC so far, but we do have our own internal drug development as well as advanced therapeutic medicinal products in that field. In RGCC, and mainly in the laboratories in Greece, in Germany, in Switzerland, in India, we put all our efforts and all our goodwill in order to do whatever it's possible to find the best possible treatment option for a cancer patient. We do not give it up, no matter what, until we reach the best possible treatment for this disease. This is our main concept. And the solution will never come from things that we already know. It will come from something innovative, something new. So research is the key for this disease.
7 steps to getting an RGCC test. 1. You arrange an appointment with your doctor or contact one from our international network. 2. You visit your doctor for a blood test. 3. The blood sample is sent to our state-of-the-art laboratories. 4. Our scientists carry out a range of personalised tests on your sample to detect any potential early signs of cancer or monitor any existing cancer tumours. 5. We produce a profile of treatments that could benefit you. 6. We share your test results and profile with you and your doctor. 7. You and your doctor develop a personalised approach to your cancer diagnosis together.
Yang total tiroidektomi, dokter?
Apa itu circulating tumor cells?
Itu, siapkan aja.
Kanker dimulai dari sel tubuh kita sendiri.
12.
Yang total tiroidektomi?
Iya, baru nomor 2.
Juga, dokter.
Jam 8. Injeksinya sama ya? Oke ya.
Paropak nomor 20.
Berpotensi mendeteksi CTC yang beredar di darah sehingga dapat membantu mengidentifikasi kanker sebelum muncul gejala atau screening. Berkat perkembangan terbaru, dapat menentukan dan memantau pengobatan yang tepat, membantu semakin banyak orang berjuang melawan kanker.
A doctor can save hundreds from a disease. A hospital can save thousands. A healthcare system can save millions. And a small team of dedicated scientists can save everyone. A seed sown in the soil germinates and becomes a plant. A plant grows to become a tree. The root of the tree delves so deeply into the soil, making it a force of nature. The journey of a seed to a tree is a tale of patience, perseverance, and silent fortitude. It reminds us that greatness often starts from the smallest beginning, and with time, nurturing, and resilience, the impossible becomes possible. Genetics pioneer Dr. Ioannis Papasoteriou, founder of RGCC, sowed the seed to revolutionize cancer care. This seed has now flourished into a global network of cutting-edge laboratories and research facilities, and countless breakthroughs have sprouted from it.
My life. So I had to decide whether I should become more missionary or more professional. So I took the road of missionary because at the end I want to sleep quietly at night. My conscience should be quiet. And also there are personal stories inside the family, close person that you actually lost or you are fighting for them. So always there is a personal story which drives you. So I'm not an exception. But at the end, I try to use every tool available to contribute to that mission. That's the old story of RGCC. This is how I actually start.
As Dr. Ioannis Papasoteriou envisioned, RGCC has achieved remarkable milestones over the past 2 decades. We are turning 20. We've come a long way in our effort to help cancer patients get personalized cancer care. Here is the glimpse of the 20-year journey. Testament to our success. Everything that we do at RGCC keeps one person in mind: the patient. In every step, every stage, we're with you. As we celebrate 20 years, we look forward to a future where advanced cancer care becomes accessible to all in need.
Selamat siang, Prof. Sehat selalu.
Ya, dari mana?
Saya, Prof.
Siapa?
Joko.
Jok. Gak kelihatan wajahnya, Jok.
Kelihatan, Prof.
Hah? Aman, kan dulu aku lihat.
Good morning, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh, and warm greeting to everyone. Welcome to webinar Meet the Expert Real-World Application of the CTC Test by Oncologists on Sunday, July 27, 2025. I'm Mas Ginawang, and it's honor and privilege to stand in front of you as the master of ceremony for today's event. In this moment, I want to express my gratitude and honor to Dr. Walta Gautama, surgical oncologist, as the Chief of Indonesian Society of Surgical Oncologists Praboy, Dr. Ionis Papasitoru as the Director of Research Genetic Cancer Center at GCC South Asia, Dr. Margareta Rosa Gunawan as the Director of PT Wapindo Jasarta Klinik Sinar Mas Sehat, our moderator, speaker, and all panelists for today's event, and also to all participants who have attended this event. This event is collaborating between Indonesian Society of Surgical Oncologists, Praboy, Research Genetic Cancer Center, RGCC, and Sinar Mas Clinic to enhance surgical oncologists' understanding and use circulating tumor cell testing in the real-world cancer care to improve oncology service quality in Indonesia. Before we begin, I would like to review the agenda for today's event. We have start from 10:30 a.m. and hopefully we'll finish on 12:45 p.m. with one moderator, 3 presenter, and 7 panelists in here. We will have several cases to discuss, and I encourage all doctor in here to share your talk and insight. Everyone, there's a few reminder for all participants. Please keep your microphone on mute during the presentation and rename your Zoom name with your full name. You may submit your question through the Zoom chat, which will be addressed during the Q&A session. Or if you want to ask directly, you can use a raise hand feature on Zoom. This webinar is accredited by the Indonesian Ministry of Health, Kemenkes, and eligible for SKP point. You can access and manage your SKP points through the official platform of Pelataran Sehat Kemenkes. Please make sure to submit the attendance form through the link provided in the Zoom chat box. Your attendance is required for SKP accreditation. Everyone, before we proceed to the opening speech, let us begin this event by listening to the Indonesian National Anthem, Indonesia Raya, and followed by Hymn of Praboy. Ladies and gentlemen, we invite you to pay respect as we listen together.
sejahtera dengan semangat penuh dedikasi. Setiap masyarakat kami layani. Berawal, berawal, mengabdilah selalu di bumi Nusantara. Indonesia tercinta. Berawal, berawal, mengabdilah selalu di bumi Nusantara. Indonesia tercinta.
Thank you. Now we are continue our program. To begin the series of event, please welcome to Dr. Walta Gautama, surgical oncologist, as the chairman of Praboy, for giving your opening speech. Dr. Walta, the time is yours.
Good morning, ladies and gentlemen. Thank you for joining us today on this webinar about the importance of the liquid biopsy. Thank you, Dr. Ionis and RGCC team for arranging the webinar to share more information about liquid biopsy. And thank you, Dr. Sarah Leong from Malaysia and Dr. Conrad Lola from Philippines, Dr. Jervin Ling from Singapore. Today we are going to learn more about liquid biopsy based on CTC performed by RGCC. For your information, RGCC and Perabo, Indonesian Society of Surgical Oncologists, have signed MOU on collaborative research on CTC liquid biopsy. The MOU was signed last year, and I hope after this meeting, the collaboration research can be effective immediately. And I also hope that the collaboration between RGCC and Peraboy can contribute useful knowledge to the community of oncology surgeons in Indonesia. Thank you for joining us today on this webinar about the importance of the liquid biopsy. Thank you.
Thank you, Dr. Walta, for your opening speech. Next, we also have an opening speech from the partner from our partner at GCC, Dr. Sarah Jen Kong Mei Leong. Dr. Sarah, the time is yours.
Thank you so much, Dr. Asta. Selamat pagi, salam sejahtera, and good morning to all much respected Dr. Walter. Thank you for having us. Our honorable professors, surgical oncologists, our partners, Dr. Rosa and the Cinemas team, speakers and participants. On behalf of RGCC, please allow me to express our deepest gratitude for this opportunity to share about the groundbreaking and revolutionary advances in our RGCC group, especially on a Sunday. RGCC and its advancements are actually more than 20 years in the making since the establishment of our group. RGCC was founded and is still spearheaded by our genius of a founder, molecular oncologist, and visionary leader, Dr. Ionis Papaswatiro. We hope to provide support to our practitioners globally with the advancements and information our tests and therapeutic solutions may provide for the well-being of the single most important party in all our quests, basically the patients. In the realm of medicine, teamwork is essential, and as we collaborate with colleagues to provide the best possible care for our patients, the patients is the heart of everything we do, and their well-being is our ultimate goal. Thank you very much, and I do hope that you will benefit from our sharings today. Thank you, Dr. Asta.
Thank you, Dr. Sarah, for your opening speech. Next, we will start our scientific session that will be moderated by Dr. Concert Joslola. Dr. Lola is an active medical oncologist and internal medicine consultant in several top hospitals in Quezon City, including Providence Hospital, Saint Luke Medical Center, and he also served as an advisor for Gene Solution Philippines, and is active in academic roles at San Beda College of Medicine. He holds a Doctor of Medicine degree, a Master in Hospital Management, and is currently completing his thesis for a Master Science in Molecular Medicine at St. Luke College of Medicine. We are honored to have Dr. Lola guide us through today's discussion. Please welcome Dr. Concert Jos Lola. The time is yours.
Thank you very much, Dr. Asta Inawang, for that kind introduction. So I also thank the officers and members of the Peraboy for inviting us in this very important gathering. So I will serve as the moderator and the second speaker for this session. Now to introduce our first speaker, in which the session will be about the role of liquid biopsy in cancer detection and diagnosis. So we have Dr. Sarah Jane Kong. So she is the Director of the Physician Development and Network Engagement of the RCC Southeast Asia. She is the Vice President of the International Society for the Personalized Metabolic Oncology, or ISMO, an occupational health doctor registered with the Department of Occupational Safety and Health in Malaysia, general practitioner, integrative oncologist, and nutritional medicine. She obtained her Bachelor of Medicine, Bachelor of Surgery, and Bachelor of Obstetrics in the National University of Ireland in the Royal College of Surgeons in Ireland, a Master's in Nutritional Medicine in Australian College of Medical Nutrition, a professional diploma in the Aesthetic Medicine in the International Institute of Wellness and Aesthetic Medicine European Standard International University in Paris, an ongoing Masteral in Healthcare Law and Ethics in the University of Dundee, an additional certification in Clinical Dermatology, Anti-Aging Medicine, Mental Toxicology, and Clinical Research in Aesthetic and Regenerative Medicine. So, ladies and gentlemen, Dr. Sarah Jane Kong.
Thank you so much, Dr. Lola, for making my CV seem so nice. Dr. Asta, do I share my slides, or would you share the slides? Okay, thank you so much. A very good morning, everyone, again. Today, I'm going to present my perspective as a primary care physician, referring patients to oncologists. So I will be talking about the role of liquid biopsy in cancer detection and diagnosis. So my first slide runs through the historical context of, do you think we could go to the next slide? Okay, so my first slide runs through the historical context of CTC establishment. So in 1869, Thomas Ashworth first found that there were cells similar to those in tumors that in a metastatic cancer patient. So he says that perhaps these might seed to secondary tumors. And then later in the late 1990s and 2000, there were technological breakthroughs in immunohistochemistry, microfluidistics, and RT-PCRs that allowed the isolation and molecular characterization of rare CTCs. And then that's where Cell Search came about, the first and only FDA-approved system for CTC enumeration. But in this context, it was for the prognosis of breast cancer, colorectal cancer, and prostate cancer. And in 2010, until now, RGCC, together with some other parties as well, have provided molecular profiling, and they provided a paradigm shift in screening by providing phenotyping, genomic analysis, and drug response mechanisms to the CTCs, analysis of the CTCs. So maybe move on to the next slide, please. Thank you. My next slide is CTCs may be used for four main broad areas: for screening, for diagnosis, for prognostic capability characteristics, and for therapy guidance. Screening is not applicable for general population worldwide. It's more promising for high-risk groups. Diagnosis it serves as an adjunct tool in selective clinical context, not in every context. But it's amazing, right now most of the evidence is for prognosis and for the guidance of therapeutics in the usage of oncology. So my next slide just basically shows how CTCs are broken off from solid tumors. They enter into the circulation. And from CTCs, you may also get cell-free DNA. May I get the next slide, please? Cell-free DNA, ctDNA, and as well as exosomes that are released into the circulation. I'm going to go very fast. Okay, so the next slide, my fifth slide, shows that based on the latest research, it says that CTC can provide insights to the malignancy of the tumor and risk of metastasis, basically providing very good prognostic value. And then when we look at analysis and the molecular and functional typing of the CTCs, it enables more precise guidance in individualized treatments of patients. But when it comes to screening or diagnostic assistance, CTCs can be detected, has been proven to be detected in patients with early stage cancers, and because of the association with metastasis, may indicate the presence of aggressive disease, thus providing a possible means to expedite treatment and diagnosis for patients, but at the same time, avoiding overdiagnosis and overtreatment of those with slow-growing and indolent tumors. So in diagnostic and screening utility, CTCs fit in, so based on the current consensus, they are not standalone tools yet and not for population screening. So that's because CTCs are very low in the presence of it in early disease. There's a risk of false negatives, and also we don't have a universal tumor marker that can screen for everything. But however, CTCs are promising for high-risk populations like those with genetic mutations like BRCA1, Lynch syndrome, even smokers. And there are currently a few trials out there that are investigating the role of CTCs in screening for lung, prostate, and breast cancer. So this is a chart that we've come up. The next is a chart that we've come up showing how carcinogenesis from the initiation of DNA damage in the cells itself, it can take 10 to 12 years before the CTC itself, before the cells itself progress to a sizable amount that can be detected on screening. So we're talking about 1 centimeter. So from DNA damage to proliferation, before it can actually promote itself and become engrafted as a tumor, you're talking about 10 to 12 years. So by the time we actually rely on that, we're talking about quite advanced engraftment of tumor. So the next slide shows that the mechanism of carcinogenesis and certain therapeutic things that we can come in with, chemoprevention, therapeutic evaluation. All these slides, do you think I can move to the 9th slide, please? The metastatic cascade module, where it shows tumor genesis involves multiple rounds of mutation and selection of fitness of genes, and then before it becomes 1 centimeter, where it's the primary tumor, and then before it metastasizes. So we're talking about a huge lead time that if we can catch it sensibly and accurately, it will provide a lot of lead time to us. So the next slide. Okay, so maybe I can go to the 11th slide. So why liquid biopsy? With advanced imaging technologies like parametric MRI, PET scan, they can still only detect a primary tumor or metastasis that are about 1 million cells, so about 5 millimeters in size. So liquid biopsy, the benefits are that it is minimally invasive or non-invasive, because most of the time it just involves a blood test. It enables repeated sampling. So for some patients, if they had biopsies done or there's surgery removal of the tumor itself, it does not provide if the tumor were to change along the line or mutate due to treatment, we face the problem of going in to resample again. So when we provide liquid biopsy, we are able to repeat the sample in the same patient to not only detect what has changed in the genetics of the cancer itself, but also to better represent the heterogeneity of the tumor cell population. So the next slide. So again, in summary, non-invasive, repeatable, captures real-time biology, and analysis of it can provide a lot of drug sensitivity profiling. But in this scenario, it complements radiology and pathological diagnosis. It's not a standalone, but it complements and supports the diagnosis of it. But the limitations are that CTCs are not very, they are very low in yield in early stage cancer. There's no standardization yet across all the different technologies to detect CTCs. It's not yet reimbursable for screening because I think screening is something that insurance companies have, they're not there yet, they don't compensate yet. And this is technologically demanding to isolate CTCs. So I'm just going to jump through my slides. So in summary, early detection is beneficial because it tends to, maybe I can go to my 15th slide, slide number 15. So early detection makes sense economically because it leads to lower treatment complexities. Like when you treat a stage 1 cancer compared to treating an advanced stage 4 cancer. It cuts down mortality, like in colon cancer, it can actually cut mortality by 60%. And its cost effectiveness. So throughout the world, there are many different bodies that have identified this, and I acknowledge the fact that early detection is going to make an economical impact. And we're talking about the European Beating Cancer Plan by the European Commission, the UK Research and Innovation Initiative, as well as NIH and the National Cancer Institute in the US. So the next slide shows that so besides cancer, when it comes to diagnostic support, CTCs provide adjunct to imaging and biopsy. It adds value in ambiguous cases, for example, where biopsy may be risky, like in the brain due to certain bone, perhaps the spine, or where it's difficult to access, like the pancreas. Also, there are certain cases where the patient may have no clinical evidence of cancer in ultrasound or any imaging, and these lesions might not be easily accessible for biopsies, and also where patients are unfit for invasive procedures. CTCs can support diagnosis confirmation, tumor origin classification by analysis of the genetic expression on the CTCs itself, and it can also show the epithelial mesenchymal transition, where CTCs lose epithelial characteristics and they gain more abilities to metastasize. So the clinical relevance, an example of the clinical relevance and the usage of CTCs in adjunct to diagnosis would be in cancers of unknown origin, which makes up about 3 to 5% of all malignancies. So this is very important. It can detect early relapses and minimal residual disease in an established cancer. It can risk stratify and give a prognostic value to the diagnosis of the cancer itself. So by looking at the different levels of CTC, so it tells us how advanced the disease is. And in our GCC, when we immunophenotype and molecularly analyze the CTC, it gives us an information about the EMT markers, the stemness markers, drug resistance, oncogene panels, and all these convert to more precise therapeutic profile planning. So the current gold standard for cancer diagnosis is histopathological, of course, but usually sometimes it involves invasive procedures to biopsy a solid tumor tissue. And indeed, multiple biopsy samples can be required. And also, even then, it provides minimal information on tumor heterogeneity. So there are evidence out there on my slide 19, where CTCs have showed prognostic utility for cancers like prostate cancer, breast cancer, colorectal cancer, as well as bladder, head and neck, and pancreatic cancer. So therefore, on slide 20, for liquid biopsy assays to be effective tools for early diagnosis of cancer, they must focus on identifying aggressive cancers that require immediate treatment and diagnosis. And the analysis of the captured CTC might have an advantage in this regard. So what do I mean by that? I mean that when we look at the CTC itself, not just the CTC count itself, but the expression of the phenotype on the CTC itself, CTC can provide information about the dormancy of the cancer, EMT, as well as the ability to extravasate and intravasate in the CTC itself. So there was a recent publication in 2023 that said that CTCs itself is good, but what's more important is the identification of clinically relevant cancer. That's on my slide 22. This was a paper that was recently published. And the future role of CTC is that they want to use CTC to detect. So not just a very objective, positive or negative CTC, but they want to analyze and look at it. So that means you identify CTCs, you go after it with imaging or any biopsies that might aid in the diagnosis of the treatment. But also they want to identify the characteristics of the CTC itself. So this is where, in the next slide, there are certain markers on cancer stem cells like SOX2, OKT4, and NANOC that is part of our test. We have an OncoTrace test that analyzes these markers on slide 24. So they talk about embryonic stem cell markers like SOX2, OKT4, NANOC, and all these expressions on the cancer itself would tell that this population of CTCs, also known as cancer stem cells, are particularly aggressive and they need to be the one to be addressed. So the next slide is an example of what the OncoTrace analysis of the gene expression on the CTC looks like. So besides analysis of CTC, RGCC has gone one step further. I'm just going to share it here because it's available, where instead of just looking at a sensitivity of about 86% for isolation of CTCs, they've gone one step further. RGCC has brought it one step further, where we do an indirect testing of our immune system's reaction towards cancer. So we look at peripheral blood mononuclear cells, and these cells they will express certain genes on the cell surface itself that identify and tell us whether is reacting towards infection or cancer. So when we can identify the group of PBMCs that are in reaction to cancers, we can say whether there is a reaction in our body to early cancer formation. That means that 12-year lead period of carcinogenesis, is there a reaction already that's happening, right? So that's my next slide. I think my slide 26. Right, so that's where PBMCs come in. And on my slide 28 is where we compare PBMCs in comparison with ctDNA, CTC, cell-free DNA, and conventional imaging. So PBMCs and our OncoDeclare test provides the earliest detection. That means cancer activity, our immune system reacting towards cancer activity, even before the formation of tumor. Right, so this leads to a lot of lead time. But again, the restriction in this type of test tends to be, what do we do with it? Because if I have a positive PBMC reaction and there's nothing on imaging and nothing to biopsy, therefore, what sort of intervention do we speak to the patient about? But I'm usually in this scenario, we're talking about lifestyle changes, quit smoking, minimizing their risk, and also vigorous screening if they are at risk, like they carry certain genetic expressions. I'm going to share two cases today. The first case is a patient who was not diagnosed with cancer. That's my slide 29. He's a 52-year-old gentleman with no constitutional symptoms. He did not have any loss of weight, loss of appetite, no jaundice, nothing at all. But he was keen to screen for cancer because of family history. He's a chronic diabetic on Biduron and sitagliptin and metformin. His blood glucose control was not very good. Usually fasting glucose is about 10 to 12, HbA1c about 10. He had elevated CA99, which is about 79 to about 90. Not very high, but just slightly high. Family history of gastric cancer, his paternal side. He was a smoker and he consumed a lot of alcohol, almost every other day, and a lot of alcohol. Physically, he was unremarkable in terms of examination. No organomegaly, no jaundice, no cachexia, nothing to indicate any malignancy. So this patient proceeded to do an OncoDeclare. So OncoDeclare was the PBMC reaction towards carcinogenesis. So he had a positive reaction. So what do we do next? So we go after imaging and we look for CTCs. So true enough, he did a CTC, and his CTC test, the OncoTrace, isolated 2 cells per mil. So there is a tumor somewhere releasing CTC into the circulation. That's on my slide 31. Right, so 2 cells per mil. And on my slide 32, you can see the gene expression of this CTC. 50% of the CTC had 25% of the CTC was positive for NANOC, which is one of the stemness marker. OKT4 was negative, that's okay, but SOX2 was dimly positive. So you're talking about there is a population in the CTC that's being released into the circulation that is aggressive, right? His CMAT was negative, so no propensity to metastasize, but there is a population that is aggressive. So what we did next was we proceeded to refer him. So there's another test that can identify, the next slide on slide 33, can identify based on the genetic expression on the cells itself, where the origin might be. So this is based on a database, so there is this test. But the next slide, we proceeded to do his analysis of his immune system to see, is there anything wrong? Why is there a CTC present? But anyway, I'm just going to jump straight to slide number 35, where this patient was referred for a PET scan. Right? So they found a physiological mass in the pancreas 2.9 cm by 1.5 cm, with some lymph nodes that were enlarged. And the impression on slide 36 was that there was a diffuse FDG increased mass, a bulky pancreatic tail with surrounding mild fatty streakiness. So this patient was eventually referred to a gastroenterologist who attempted a biopsy via ERCP, and the pathology came back as a neuroendocrine tumor. So now they are planning, so the next slide would be the biopsy and the neuroendocrine tumor. So currently they are planning to start to get it surgically removed and to start on a protocol. So we also proceeded to do on slide 38 an Onconomics Plus, where we look at the different analysis of the different possible chemotherapy drugs that might work for this patient. I think we'll just run through it because I'm not the one covering the therapeutics. Dr. Lola will help us with that. But we proceeded with Onconomics Plus because of the nature of the cancer itself. And on slide 42, you can see that he had very elevated resistance factors. But there was some sensitivity towards some immunotherapy. And if you can see from slide 45, let's just go through it very fast. Slide 45, 46, there were different upregulation of oncogenes that attributed to the formation of this cancer. Right, so now let me jump straight to case number 2 because I'm just talking about screening. So that case was a case of screening. Case number 2 on slide 49 is a case of monitoring of minimal residual disease. So this particular gentleman is a 66-year-old man, also without any symptoms. He wanted to upgrade his insurance in Singapore and they detected an elevated free PSA. So his free PSA was 7%, and they said that anything less than 10% is high risk. So he underwent a few different MRI prostates, and they found small little lesions, too small to biopsy, so they never got histopathological result from that. They ablated it and told him that he was fine. So if you see this follow-ups, his total PSA was never elevated, it's only about 3. So subsequently, after the ablation, his prostate level, total PSA dropped to 0.94. And he came to me saying that he is free of cancer. He says he is an absolutely normal patient right now. His PSA is 0.94, so he is confident that he does not have any cancer left. Number one, because the oncologist did not have any treatment for him. But he also wanted to go one step further by wanting to do mesenchymal stem cells. So mesenchymal stem cells have the danger of also propagating cancer stem cells if they are present in the body. So I said I would screen him first. So I did his PSA. Again, it dropped even further. It's 0.34. So he was very happy that he had no cancer. But I proceeded to do an oncotrace for him. So the oncotrace isolated 2.2 cells per mil. So he still had a tumor that was releasing CTC into the circulation. And if you look at so that's slide 52. And if you look at slide 53, you would see the gene expression on the CTC itself. NANOC was positive for 25%. OKT4, SOX2 was dimly positive. What's interesting is the PSMA, which is a marker for prostate, was 100%. So all of it was prostate in origin. And the CMAT was dimly positive. So we're talking about an origin of a tumor that is particularly aggressive. So I tried to educate the patient that, right now there may not be any active intervention by your oncologist or by a urologist, but we cannot take any risk by doing things that would be dangerous. So my last 3 slides, slide number 54, there was a news article recently in the US, in the UK, saying propagating liquid biopsy for cancer screening. So they're saying that, you can detect cancer as early as 3 years before the establishment of the actual cancer itself. All well and good. But the expert emphasized that we also need to determine the appropriate clinical follow-up after a positive test for such cancers. So this is where primary care physicians work together with oncologists, where we monitor, we talk about lifestyle changes, and we refer and work together with oncologists to be able to help us to actually make use of this test, make use of the lead time where early cancer detection is about 99% in breast cancer, and it goes down to 32% in advanced breast cancer. So in summary, the advantage of CTCs lies in their complete cellular morphology and intracellular contents that are analyzed, and they possess an ability to provide the complete genomic transcriptome, proteotome, and give information about invasion, proliferation, and metastatic capabilities of the CTC. So it's comprehensive and provides high reliability of the results. So these are my references, and I thank you very much for paying attention to me. Thank you so much, Dr. Lola.
Thank you so much, Dr. Akong. So we will entertain questions after we finish all the three speakers. So for the second speaker, it's me. So I think I'm already introduced a while ago. So may I request for my slide? Okay, so I'll be the one who will share my screen. Thank you. Okay. Can you view my slides now?
We can, Dr. Lola.
Okay, thank you. So I will be discussing about the functional application of liquid biopsy in the personalizing cancer treatment. And because of the interest of time, I will be focusing more on the pharmacodynamic test, which is our oncologic test. So to start, oncologics is a form of what we call the pharmacodynamic testing, which determines the efficacy of therapeutic agents. That is, we determine what does the drug do to the body or do to the tumor. So we have two important parameters that we include in oncologic tests. So we have to determine the efficacy of specific drugs by doing the gene expression profiling by your DNA microarray, and also to do the viability assay or the sensitivity test to validate
Dr. Lola,
any
Dr.
data that we obtained from the gene expression profiling.
Dr. Lola, so sorry, Dr. Walter raised his hand.
Yes.
Dr. Walter?
Thank you, Dr. Lola. Thank you, Dr. Sarah, for your interesting presentation.
Thank you, Dr. Walter.
I am interested about your presentation and your case sharing. For early detection, we use CTC test, and when we found the CTC, can we diagnose for the high-risk patient?
I think Dr. Walter, over here in Malaysia, when we detected the CTC, I needed the PET scan to show an imaging, and then I referred the patient to the oncologist. Then they insisted on a biopsy to diagnose the patient. I think without it, they probably would not have jumped to a diagnosis of cancer yet, Dr. Walter. Dr. Lola, Dr. Walter, that would be correct, right? Even in your
Yeah.
practice.
We need the imaging and the histology confirmation of malignancy after we detect the CTC by the initial screening procedures. Dr. Walter, do you have any further question? Dr. Walter, you're still unmute.
Thank you. Can we check the origin of the cancer when we found the CTC in blood test?
There is one test, Dr. Walter, called the ACGH by RGCC. But the limitation of that test is that it analyzes the gene expression on the CTC. And then it refers back to a database, the COSMIC database. Dr. Walter, I think you know that Dr. Yunis mentioned that it's the COSMIC database. And based on that information correlated with our gene expression on the CTC, it gives us what they think it is. But sometimes we're limited by what's in the database. So if the database is not very current, Dr. Walter, then it might not be so accurate. But we do use that that test in like carcinoma unknown primary, Dr. Walter. We use it as an adjunct to the diagnosis of the cancer.
I use the CTC test for the advanced cases, and the patient no need to
do so many imaging, Dr. Walter.
Yes, I have imaging for the advanced stage of
to monitor them, right, Dr. Walter, to see how
Yeah.
they progress it.
renal cancer. I have a patient
That's the
with
main
renal cancer. Yes.
that's the main use of it, right, Dr. Lola?
For cancer screening, the molecular diagnostic, cancer screening molecular diagnostic aims to complement the conventional cancer screening. So even if we have a positive for CTC and also we have a test which points to a specific malignancy, still we have to do the recommended screening procedure and the recommended conventional histopathological confirmation of malignancy before we can label the patient to have malignancy and also to do the proper staging of the cancer. Dr. Walter, you still unmute?
Yes. I want to share my case with a suspicious prostate cancer. No need to biopsy. And then I use the CTC test with the laboratory PSA tumor marker for the prostate specific antigen more than 1,000.
Wow.
And then I do the treatment for the prostate and check the PSA.
Wow. Dr. Walter, what treatment protocols did you use for that in that case?
I treat with Zoladex and I treat with Zoladex and Casodex. Patient with advanced prostate cancer, metastatic to the bone.
Hello, Dr. Walter and Dr. Lola. For this session, I think we let Dr. Lola go through his case because Dr. Lola have a very interesting case to share, and then we can go to the another Q&A sessions after the presentations. Okay, so Dr. Lola, please continue. Thank you very much.
Thank you so much. So to continue, it is always a rule that we do a double platform because the gene expression profiling does not always to have a linear relationship with the protein expression. After your initial transcription, we have what we call the post-transcriptional modification, like your RNase silencing or interference, and also the effect of the glycosylations that affect the folding of the protein. So in order to confirm the information that we have from the gene expression profiling or the data that we obtain from the DNA microarray, we double check it with the result that we obtain from the cytotoxicity or the viability test, wherein we expose the cancer cells to these active substances. So for chemosensitivity testing, these are the cytotoxic agents that included in the testing. So we have the alkylating agents, the common ones, the platinum compound, cisplatin, carboplatin, and the alkylating agents, cyclophosphamide and ifosfamide. For the topoisomerase inhibitor, we have your CPT11 or irinotecan, topotecan, your doxorubicin, liposomal doxo, epirubicin, etoposide. For the epotelones, we have the ixabepilone. For taxanes, we have paclitaxel, docetaxel, and also we have eribulin, abraxane, cabazitaxel, and the binca alkaloids, bincristin, binblastine, binorelbin. And for the nucleoside analogs, we have your fluoropyrimidine, 5-FU, and capecitabine, and also the other analogs, methotrexate, gemcitabine, pymetrexate, and fludarabine. We also have your monoclonal antibodies with its targets like your alemtuzumab for CD52, your immune checkpoint inhibitors targeting PD1 or PDL1. So we have your atezolizumab, abelumab, pembrolizumab. For anti-HER2 targeting agents, we have your trastuzumab and pertuzumab. And for anti-CD20, we have your rituximab, tositumumab, and ibritumumab. For small molecules, we have the hormonal therapy, the small multi-targeted tyrosine kinase inhibitors, your PARP inhibitors, and mTOR inhibitors. Slide. For the chemosensitivity part, we have the we utilize the 3D culture. 3D culture allows the cells to grow in a three-dimensional aggregates with the use of scaffolds like your hydrogels. It incorporates the organoids or the cells embedded in the cultures that mimics the extracellular environment of the tumor. And 3D culture promotes cell-to-cell interaction, allows the cell to interact with the extracellular matrix. So this type of culture is a more accurate in vivo representation of the tumor. We have a test we called Onconomics Plus, which aside from detecting sensitivity for cytotoxic chemotherapy and targeted therapy, this includes the sensitivity for the natural products like your class 1 cytotoxic agents. So we have here your artemisinin, amygdalin, agaricus, ascorbic acid, and cordyceps, and so on. For class 2, the immunostimulants or immunomodulators, we have your IPA, lipoic acid, boswellia, mistletoe, Timex, Brixton. And for the protein kinase inhibitors, we have your angiostav, apigenin, your coenzyme Q, cocormin, genistein, and others. Onconomics Plus or Onconomics result is presented in a scientifically based and complete report, easy to understand even from a non-expert, easy to interpret, and easy to combine the information with the other information. The accuracy of the CTC detection with the RGCC test would provide a sensitivity of 86.67%, a specificity of 83.33%, positive predictive value of 83, and negative predictive value of 86. As compared with the FDA-approved CTC determination, it has only a sensitivity of 20 to 57% and specificity of 77%. Now, based on the in vivo sensitivity and gene expression profiling, is there any correlation with clinical response? Yes, we have this series of reports that we have. So in breast cancer stage 4 patients in which they completed at least 3 cycles of chemotherapy with good performance status, we still have report using Onconomics. We reported complete response of 7%, partial response of 47%, and a stable disease of 13.2%. Remember that with empiric treatment, we only have 20 to 30% response rate for third line or beyond using chemotherapy. For colon cancer stage 4, also heavily treated, 3 or more with good performance status. Likewise, we have a good report on complete response, 6.8%, partial response of 41%, and stable disease of 42%. For a larger series of patients, in 254 patients, we have 12.2% in complete regression, partial response of 40.6%, and minor response in 12.9%. I will now share some of our tests which uses the Onconomics. So first is a 65-year-old female presented with breast mass and right axillary adenopathy who had a CT scan with an initial size of the right breast mass at 6.2 by 4.3 by 4.6 with ipsilateral anterior chest wall and axillary adenopathy. Biopsy showed invasive carcinoma with lobular features. So we have clinically stage 3B. It is hormone positive, ER and PR positive with HER2 negative. So patients receive an initial neoadjuvant chemotherapy, 4 cycles of doxorubicin, cyclophosphamide, followed by 4 cycles of paclitaxel. So patient eventually underwent the modified radical mastectomy, and biopsy showed positive for tumor involvement in the nipple and skin, and positive for nodal metastasis in 4 out of 6 lymph nodes. So neoadjuvant pathologic stage is YP, T4, YP, N2A, and M0, which is stage 3B. After surgery, patient underwent radiotherapy and also started with adjuvant hormonal therapy using letrozole at 2.5 milligram, and also underwent the regular surveillance using CT scan of the chest and upper abdomen every 3 months. Around 11 months after the initial mastectomy on the right, there is now an appearance of lymphadenopathy on the left, measuring 1.8 by 1.9. Although breast MRI did not show any mass, additional PET CT scan showed axillary lymphadenopathy, which is most likely metastasis. Biopsy of the axillary node showed hormone positive, ER positive, but PR negative, still HER2 negative. Patient had a formal modified radical mastectomy, showing no evidence of malignancy in breast, but have a positive nodes, 3 out of 9, with a histologic diagnosis of invasive ductal carcinoma. So we have a clinical stage of a pathologic stage of PT0, PN1, and M0, which is stage 2A. So while patient is advised to undergo onconomic test, and while waiting for the result of onconomic test, patient started with chemotherapy using cyclophosphamide, methotrexate, and 5-2-uracil. This is one of the recommended chemotherapy for post-operative setting. However, the oncologic test showed that there is only partial sensitivity to cyclophosphamide, also partial sensitivity to 5-FU, and no sensitivity to methotrexate. The sensitivity test showed a high response to cisplatin, carboplatin, and also to gemcitabine. For the expression profiling, it shows no significant expression of your HER2, increase the proliferative signaling and the mTOR, RAS, RAF, and EGF, also increased expression of the hormone receptors, estrogen and progesterone, and also increased expression of those molecules involved in the cell cycle pathway, your E2F and CDK4 and 6. So just to further illustrate the role of these molecules, so cyclin D is produced by the different proliferative pathway like your EGFR, PI3K, and also your RAS, RAF, WNT, JAK2, and your estrogen pathway. Once your cyclin D is produced, it associates or goes with your CDK4 and 6, activating the CDK4 and 6. CDK4 and 6 in turn phosphorylate your retinoblastoma protein, and upon phosphorylation, the associated E2F protein dissociates from the E2F RB complex, and your E2F goes inside the nucleus and cause the expression of your CDC25, cyclin E, and cyclin A, promoting your cell cycle. So based on the high sensitivity for gemcitabine and carboplatin, the post-operative chemotherapy was shifted from cyclophosphamide, methotrexate, and 5-FU to gemcitabine plus carboplatin for 6 cycles. Patient also had a next generation sequencing, which only showed deletion mutation at p53 resulting to frame shift mutation. There was no mutation associated with breast cancer genes like ESR1, PALB2, PI3K, and BRCA1 and 2. Now, with regards to hormonal agents, the sensitivity test showed sensitivity for hormonal agents like your anastrozole, exemestane, fulvestrant, and tamoxifen, and also sensitivity for mTOR inhibitor, everolimus, also sensitivity for CDK4 and 6, palbociclib. So after radiation therapy to the left axilla, patient was maintained on abemaciclib, which is a CDK4 inhibitor, and fulvestrant, selective estrogen receptor degrader. So patient is still currently maintained on this regimen and will have the repeat CT scan around 2 to 3 months from now. Patient still doing well. So the next case is a 60-year-old lady diagnosed with invasive breast carcinoma and also a positive metastatic carcinoma on the axillary node on the left. The hormonal status is negative. The immunostain ERPR were negative. The initial immunostain for HER2 is equivocal, so patient eventually undergo fluorescent in situ hybridization, showing us result of HER2 CEP17 ratio of 1.8, which is negative. So we have a triple negative breast cancer in this case, a high proliferative rate of 60 to 70%, and positive PDL1 at a combined proportionate score of 30%. Baseline CT scan showed a breast mass on the left at 3.1 by 3.7 by 5.5 cm with an enlarged axillary node at 1.3, normal but increased uptake on the hilar, mediastinal, and internal mammary lymph node, also increased FDG uptake on an enlarged bilateral adrenal gland, enhancing nodule on the inner aspect of left breast. There was also note of a left temporal mass in the brain, which is interpreted as metastatic with a size of 0.8 by 0.7 with associated minimal edema and sub-centimeter right breast nodule 0.3 by 0.4 cm. So patient has a baseline oncologic test. So this oncologic test showed the high sensitivity for cyclophosphamide, also for topoisomerase 2 inhibitors like your doxorubicin and epirubicin with partial sensitivity to liposomal doxo, idarubicin, etoposide. It has also a high sensitivity to taxane which is 80%, and also partial but high sensitivity to paclitaxel, Abraxane, eribulin, and partial sensitivity to epotilone, your hexabefilone, and cabazitaxel. No sensitivity for the nucleoside analogs like your 5-FU, methotrexate, gemcitabine, capecitabine, and pemetrexed and ralitrexed. Now going to the gene expression profiling. So it showed an increased estrogen receptor expression, which is in concordance with the immunostaining property, which is ER positive. And also it shows sensitivity to anastrozole and exemestane. Also increased sensitivity to other hormonal agents like fulvestrant and tamoxifen, and increased sensitivity to CDK4 and 6. But in spite of increased expression of PARP, it has no sensitivity to niraparib and olaparib. For the immune checkpoint receptor and ligand, PD-L1, PD-1, and PD-L2 are all negative, and also no sensitivity for immune checkpoint inhibitor, pembrolizumab, avelumab, and atezolizumab. Your ERCC1 are the repair mechanism proteins which repair the damage caused by your platinum compound. It's also highly expressed. So for the NCCN recommendation for PD-L1 with CPS more than 10, in which in our patient it is 30%, so it is PD-L1 positive. And also we have partial sensitivity to taxane like your paclitaxel, and also for carboplatin. So it is opted that the patient start with chemotherapy with pembrolizumab combined with paclitaxel and carboplatin, initially given for 3 cycles. The option of radiation therapy was also discussed with the patient. However, since the mass is less than 1 centimeter and the patient is asymptomatic and there is a molecular target, they opted to just start with chemotherapy. After 3 sessions of chemotherapy, there is a good partial response showing regression of the breast tumor to 1.8 by 2.4 with metabolic regression of the lymph nodes on the hilar and mediastinal area, also regression in the adrenal glands, resolution of the nodule in the left breast, and stable left temporal lobe mass. There is also correlation with MRI of the brain done in May of 2025, in which the left temporal brain mass should decrease to 0.4 by 0.3 by 0.3 centimeter. Repeat PET CT scan after 6 cycles of chemotherapy still showed further decrease of the left breast mass, also decrease in the size of the left axillary node. However, there is now development of left pleural effusion and significant increase in the FGD albid in the adrenal gland, also an FDG albid in the mesenteric and perihepatic lymph node, and there is also now an FDG focus in the segment 5 of the liver. A repeat oncologic test was requested due to this mixed response, and patient recently developed left-sided weakness, so we are awaiting for the result of cranial MRI. Repeat oncologic test was requested. It now shows partial response to the platinum compound cisplatin, carboplatin, and no response now to your cyclophosphamide. Also no response to the topoisomerase agents. There is now an increased response to your nucleoside analogs like your 5-FU and also gemcitabine and capecitabine. However, we have to take note that increased expression of the target enzyme, which is thymidylate synthase, which might decrease the sensitivity to this nucleoside analog. There is also increased sensitivity with Binca alkaloids at 81%, and also partial response with the taxane and epotilones. P27 is low, but we have an increased level of your multi-drug resistance gene and also the multi-drug related protein at 30 and 35%. In spite of the increased level of the angiogenic ligand like your VEGF, there is no reported sensitivity to anti-angiogenic agent like your bevacizumab and ramucirumab. And similar with the first onconomic test, still negative for your receptor and ligand for immune checkpoint, PDL1, PD1, and PDL2, and still no sensitivity seen for immune checkpoint inhibitors like your atezolizumab, avelumab, and pembrolizumab. For the hormone, there is a decreased expression of your hormone receptors, and also now there is no note of the sensitivity to hormonal agents. There is still increased expression of PARP inhibitor, but now there is noted sensitivity to PARP inhibitors like your niraparib and olaparib. So the summary of the onconomic test showed high sensitivity for beta alkaloids, gemcitabine, 5-FU, and capecitabine. So we can give this as a monotherapy, or we could also have the option of giving it as a combination, like combination of gemcitabine and beta alkaloids, vinorelbine, or combination of gemcitabine and capecitabine. However, with this combination, we have to take note the increased thymidylate synthase expression, which could may result to a decreased response of this combination chemotherapy. Also noted will be the high MDR and MDR-related protein, in which combination chemotherapy might be more applicable in order for us to saturate the efflux pump. We also have to consider the brain penetration of this cytotoxic chemotherapy. There is increased expression of the PARP and also sensitivity to the PARP inhibitor niraparib or olaparib. However, we don't have the BRCA1 and BRCA2 status, in which if it is wild type, it denotes that there is a double strand break repair proficiency, so that any mutation that would brought about by PARP inhibitor and resulting to double strand breaks could be still repaired if you have a wild type BRCA status. So I think, and for this case, we have to check the germline BRCA mutational status. Local treatment would also be recommended if with brain progression like your radiation therapy. So for the second line treatment for triple negative breast cancer, we have PARP inhibitor. In this case, we have an increase in level of your PARP and also sensitivity to your PARP inhibitor like your niraparib and olaparib. Although it would be prudent to check the status of the BRCA mutation, the germline, because it could repair the double strand break if there is a wild type status of your BRCA1 and BRCA2. We could also use systemic therapy, but most of the systemic therapy would have a poor brain penetration, especially in cases of patients with brain metastasis. But we could add localized treatment like your radiation, radiation of the brain. For those expressing low HER2 expression, like in our patients who have an initial +2 immunostain, although in our onconomic test, there is no expression of your HER2. In this case, we could use pamtrastuzumab and deruxtecan. The trastuzumab is a different molecule from the famtrastuzumab and deruxtecan because this is an antibody drug conjugate, whereas your trastuzumab is only a naked monoclonal antibody. And your pamtrastuzumab would also have said to have a good activity with brain metastasis. So this is also one of the good consideration for this case. So that's the end of my slide, and thank you. So for our next speaker, so we have Dr. Ionis Papasitriou, who is a specialist in cytometry. He is the founder and the director of RGCC International, a pioneer in molecular oncology and personalized cancer care in CTC and stem cell, a certified Class A cytometry expert by Bundes Pharmaceutica, responsible person for Swiss Medic, an international council for harmonization and good clinical practice in Europe, and FDA ensuring compliance with global standard. He obtained his Doctor of Medicine degree at the Medical School of Thessaloniki University, Greece, specialization in human genetics at University of Zurich and Hematology Oncology at MLU UKH Halle and Saale, and also master's degree in molecular biology in medicine at Westminster University and Oncology, University of Nottingham, a PhD in MLU University in tyrosine kinase inhibitors and human cancer cell genetics. So colleague, let's welcome Dr. Yonis Papasitoryu. Thank you.
Well, thank you so much for the introduction. Good morning to everyone. Good afternoon, actually, to you. It's very early in the morning here in Europe, but nevertheless, the topic is very interesting in precision medicine. I would like to make a very short presentation because the previous speaker covered many of the actual, let's say, practical aspect of the test. I'm going to make a little bit of a sum up. So I will share my screen. Hopefully that this will work. Okay. So RGCC actually has been founded under the need of actually understanding the biology and the behavior of cancer as a systemic disease. So the practicality behind is how to answer the question how this disease is actually behaving from the metastatic aspect, how actually the resistance is taking place, what is the critical factor which defines the systemic behavior and the heterogeneity of the disease. Because at the end, this is what we deal in our clinical practice. A highly heterogenic disease which becomes worse and worse in every stage of recurrence. And at the end, we have different sites behaving from small to big differences compared to the primary tumor. And this is where the things becomes very complex. And actually, this is the reason why always our guidelines works really well on naive patients, but after few recurrences, our guidelines offer very limited benefit. And actually, they stop give a recommendation after a point, and still the patient is on the treatable arm simply because the performance status is still allowing to receive treatment. So practically we have an ethical dilemma. Do we treat the patient or we send them to the palliative arm simply because we don't have many options? So RGCC has started working in the field of how dissemination is taking place, what is actually happening from every side of the tumor, primary or metastatic. And this is the reason why we have heavily involved on metastatic entities, liquid biopsy. And liquid biopsy is not only about CTCs. It is involving circulated tumor cell because this is the entity which do generate the metastases, how the disease is actually moved from the primary site, how it actually moved to secondary deposit organ, stays there, interact with the rest of the cells, and move forward to the new metastatic sites in order to develop the primary niche on the secondary organs. So based on that, we have developed several assays. We put them on validation, we optimize them, and we now present to you with several assays in order to identify, enumerate, and profiling from the genetic and transcriptomic aspect, the CTCs. But it's not only the CTCs that define the liquid biopsy. Nowadays, you're more familiar with them, let's say more simplified, if I could use the term, entity, the ctDNA, the circulated tumor DNA, which is actually fragmented part of the genome from the two primary or secondary tumors, and hoping to let's say, mapping this profiling from these tiny pieces of the original genome of the tumor that the patient carries, in order to identify relevant mutations for recommending targeted therapies mainly. Additional entity that involves the liquid biopsy term, involved in the liquid biopsy term, is the exosomes, which is by far not known, recently entered to our interest, but it plays a critical role of communication between primary and secondary sites. And nowadays we have realized the importance of these vesicles, which allow the movement of genes, proteins, molecules that they allow the interaction between different sites of the tumor. And of course, the old school of biomarkers, the proteins or complex proteins that the tumors excrete to the periphery. And they have only prognostic value when these proteins are present. This is quietly known years now that not all tumors excrete cancer markers, so practically we can use them only for prognostic value when they are there. This is it. Because the liquid biopsy is not one entity, it involves a complex sequence of assays. This is the reason why we have done several setups of laboratories around Europe, mainly. We have only one lab in India, and different sites in order to offer our services around the world. So as you can see, we have all of them on GMP graded, clear, accredited, ISO 15189 as well accredited in order to fulfill the requirements of every corner of the planet in different countries and serving different disciplines. So it's not a typical clinical laboratory as you know it. It's a highly standard, highly classified laboratories with clean rooms, which defines precision from the behavior of personnel and what you're actually performing inside these rooms. And as I said, different corners of the planet have different requirements, and we are obligated to fulfill all of them. From the aspect of Europe, what is required is the ISO 17025 or the 15189. But the other side of the Atlantic, they want their own, let's say, system of quality, which is CLIA and CAP accreditation. And our laboratories carry both sides. This is the most widely and recognized accreditation system and quality management from the two major entities. Most of the countries, they follow these kinds of prototypes. As far as I know, your country follows partially both. So we are exactly in that field. So the previous speaker has done my my short CV. This is who I am. So practically, I'm a little bit of an hybrid because I have done my first specialty in human genetics as well as I have been specialized as a hematologist oncologist. And this is the reason which gave me the advantage to combine both worlds and move forward on being involved in liquid biopsy and developing these kind of assays and create these setups. Because we are fulfilling high standard requirements, we are one of the, let's say, top leading companies in Europe, at least. And yeah, we try to answer this. What is liquid biopsy? What is the clinical utility in the clinical practice? And not only involving CTCs, but all liquid biopsy entities. So for the time being, this, yes, the most widely known, but limited on offering clinical benefit is the ctDNA, because it's more simplified by analyzing CTCs. When it is performed in the primary tumor, you have the whole genome available, but practically it represents only the behavior of the primary tumor. It doesn't give you an insight from the metastatic or the systemic behavior of the disease. And still, it may give you option only for targeted therapies, which they are related with specific mutation. limits. No matter how, let's say, advanced the technology could be, this is the limit of utility, because at the end we need to take information from the test and convert them to clinical decisions. This is why we are here. What we try to do is developing what nowadays is called molecular tumor board in Europe, and recently has been involved in the consensus of decision on difficult and recurrent cases. So actually, I'm trying to answer questions that I have already received already from your group, whether these, let's say, test of analytics in liquid biopsy do recommended by at least ESMO or ASCO. Actually, they do. NCCN guidelines, you know very well that after multiple recurrences and when the guidelines are failing, actually they push you to go on liquid biopsy or molecular techniques in order to identify and make decisions when the guidelines have no clear path to recommend you a protocol. So practically they do have a position, but this means that we need to create a structure how to make this decision, how to interpret the results, how to convert this data to clinical decisions. Are we going to use an in-label or off-label use? This is something that also we have to consider. And keep in mind that these kind of tests, no matter from which they are coming from us, from another company, they only give you the sensitivity of the medications, but they don't give you an insight of how tolerant the patient could be receiving this medication. And this is something that you have to assess from your end. This is why the molecular tumor board is highly recommended, at least from ESMO. Especially after April 2025, it becomes an official entity nowadays. I'm going to show you later on these recommendations as well. So the reason of why we are working with liquid biopsy is because there are several types. So we need to have an understanding what they are, what they can offer, what is their actual role in this whole process of metastases, recurrences, spread of the disease, to which sites they are going to do that, why they are different from the behavioral perspective, why do we have this heterogeneity. So for instance, in old school, we always rely on a pathology reports and we say, oh, it's an ER positive tumor. And we expect that the tumor will behave the same aspect to all sites. Well, this is not true. We know that it has been proven and we have to digest it. As simple as that. Not all sites of the disease is going to behave in the same manner. And liquid biopsy is going to represent you the behavior of the disease as average. It represents more the metastatic site and the systemic disease instead of the primary tumor. This is the reason why we have seen differences between the primary tumor analysis and liquid biopsy, as well as the metastatic site. And what they come to cover, they come to cover exactly the problems of case management when the disease becomes recurrence and it is metastatic, of course. And there is no option either to gain access to the metastatic sites and get a sample, or the metastatic sites are multiple, and we cannot do a profiling as one entity. Type of liquid biopsy, I had described that verbally. They are the circulated tumor cells. They are the ctDNA, which may fragment it. It is fragmented, actually. They are the exosomes and the circulated protein, which is the oldest type of liquid biopsy as we know it. So primary versus liquid biopsy versus CTCs, what are the similarities and the differences, and why we see differences from analysis of them? There is a huge database in a global level which is called COSMIC, and this is located in the UK. The whole world is contributing there by doing analytics in genomic, transcriptional, behavioral, between CTCs, primary tumor and metastatic sites. And as you can see, CTCs overlapping between the primary tumor and the metastatic site. This is what gives them value, because we can develop understanding about the total behavior of the disease between the primary site of the tumor as well as to the metastatic sites as well. So practically we could make more precise decisions, catching up of how the systemic disease behaving and not only the primary. Now, circulated tumor DNA. We have to understand that it is, as I said, fragmented part of the genome which derived from the tumor site. And as well, we have to understand that it may come from the necrotic part of the tumor, which doesn't represent the recurrent and the active site, which means the site that is going to create the metastases. It may come from the apoptotic site of the tumor, which is the well-behavioral type. So this part of the tumor is not the one who carries tumor-initiating properties, or otherwise widely known as cancer stem cell-like, because these are the cells that they are producing the metastases, and they carry all the features of resistance. Only the secretion part of the tumor, which generates these fragments of DNA, may have a value. And if we are lucky that they may carry the relevant mutation, which they can be driving mutation to the tumor, we may get a decision based on this data. These are huge limitations. And the recovery rate of the DNA of these fragments is really good, but still it's only pieces of the total genome. This is the reason why we cannot use so, let's say, robustly the ctDNA as a decision making as standalone, simply because we are taking small pieces from the genome of the tumor. So if we compare the two entities, these are the pros and cons. And this is not by us only. Everyone is knowing that what is the actual value. The CTCs actually protects the genome, the total genome of the metastatic site of the tumor. If we want to do even an NGS on CTCs, it is possible, and we can get credible data from them, compared to the ctDNA derived from the serum, which is highly fragmented, and we could do very limited assays. So practically, there is a huge difference from the benefits that we could get between CTCs analytics and ctDNA. And this is even more. So practically, if we could stay on the application, because at the end, we need to have an understanding about the clinical utility of this, is that by analyzing the CTCs, no matter what technique you're going to use, you can do an early diagnosis simply because the dissemination is taking place on early stage of the tumor. We could see the progression on tumors on all stages simply from the phenotype of the CTCs. Because they represent the average metastatic site of the tumor, we could, by using chemosensitivity assays, we could see the behavioral of the tumor after exposure on drugs, and we could do further multi-layer analytics, which compared to the ctDNA, we could relate with the grade and stage of the disease, and based on the volume of ctDNA, we could make a correlation with the disease progression. This is it. Of course, there are plenty of assays out there on CTCs. The reason why we use a sequence of assays starting with microfluidics, flow cytometric techniques using negative selection gives the advantage that we are actually isolating all the subpopulation of CTCs which they drive the disease. By selecting the cells by let's say, assuming that they are all EBCAM positive, we actually lose subsets which are on critical stage on EMT, and we lose information which are driving the disease progression. And as long as you can isolate the relevant population of CTCs, you can proceed on several analytics. And this is a comparison between one type of assays and others. What is recommended is not to substitute what we are doing, simply to add and fill gaps. We're not going to alter much of what you're already doing. Simply we implement assays in order to give you more flexibility on difficult cases. So again, we are addressing to patients which are in the treatable arm. Again, the ECOG score or Kanovsky index is going to define you whether your patient is going to be on the treatable arm or to the supportive arm. So to the stage of the disease, simply what we are using so far, they have a very poor limit of detection. That means that even if you are using a PET CT, you cannot see a tumor which is less than 10 in the 9 cells in volume. That means 0.5 centimeters in diameter. Below that, we can see nothing. That means that when we say that the disease is actually stage 1, we could miss multiple colonies which are there. They are less in this volume, and practically we misstage the patient. And this is what actually happens. We assume that the disease exists only in one side. We treat this side only based on the information that we get from this one. And practically, when the recurrence is happening, it happens from microcolonies that they were originally there. Simply, they were too small to see them. Simple as that. So this is where liquid biopsy can give you an insight based on the number as well as of the phenotype of the cell. So we could have better understanding whether the disease is more, let's say, from what we see macroscopically compared to what is actually happening. When the disease is advanced, as I said, the analytic methods that they could give you, that they have been described from the previous speaker, how the diseases behave from the systemic aspect. They are going to give you what is called pharmacodynamic, how the disease behaving after exposure to specific medication. It doesn't tell you how the patient is behaving after exposure of this drug. Can they tolerate it? This is the pharmacokinetic. These are the data that you have to fill in with every liquid biopsy assays or chemosensitivity assays in order to make a decision. That means that all options that they are presented to you by the chemosensitivity assay, they need to be filtered down to realistic options that patients can tolerate. As simple as that. This process is going to make you decide which kind of protocols you're going to apply. Now, if we're going to do this kind of analytics on really early stage of the disease, I can tell you now we're losing money, simply because we're going to confirm what the guidelines recommend again. So there's no reason to do that on naive cases or easy cases, which you do have options. Practically, we are addressing on advanced or difficult cases of disease in order to generate options on patients which are still on the treatable arm. As simple as that. As long as the patients are in the treatable arm, then the follow-up is recommended. Liquid biopsy can be a very good tool to follow up a patient, simply because the number of CTCs are really correlated with the total volume of the disease, as well as the phenotype. The phenotype actually is more closely related with the behavior of the disease. And yeah, because many patients are actually receive nutraceuticals, these kind of assays, they could as well address to them, and they can be applied on patients on poor performance with the hope to improve their status. Now, as I said, because we want always to put ourselves to the limits, we always assess and validate from the clinical aspect the value of our assays on actual samples. I'm saying that because most of the assays which they are presented to you, they are coming with artificial samples or otherwise spiked samples. These are by far not realistic, simply because the spiked samples are very optimal. They are monoclonal, which doesn't happen in reality. The tumors in an actual patient are highly heterogenic. They are not behaving in the same manner from one end to the other. And by assessing our assays of isolation, detection of CTCs, and find the behavioral, the sensitivity and specificity comes to these kind of limits. Hoping to improve by improving the methodologies. We know that flow cytometry is one of the methods that give really good linearity between the number of CTCs that exist and the recovery rate. That means that you can identify the cells with accuracy, but as well as to correlate with the actual volume of the disease on a patient. On a very low volume, which means very early of the disease, to a large volume, to large extension of the disease. Also, there are other assays when we want to identify from a carcinoma known primary origin from where this tumor is coming from. This is what is more commonly known as molecular karyotype, but the actual name is called as ACGH. It can detect specific alteration in the genome, which is correlated with specific primary tumors. And this gives a very good sensitivity. And as long as our database is becoming more enriched day by day, this sensitivity and specificity becomes higher and higher. But we have to see what is the actual value on clinical cases. And this is the reason why we are always recommend pilot studies, trials with different locations. One of them was with the University Hospital in L'Aquila in Italy, which shows clinical benefit on melanoma cases after recurrence and failures on primary lines. And as you can see, it did generate clinical benefit on practically lost cases. The same on refractory case on ovarian carcinoma after failure of the two lines of disease. But also we are using the phenotype of the CTCs, of how they are behaving, but as well as the alteration that they take place using multiple or large data analysis and pattern recognition. I don't like the term AI. In order to identify where and how the disease is going to become able to develop a recurrence and to which site they are going to metastasize. Also, we have, in cooperation with University of Kiel, we manage working under the same concept to identify 3 novel biomarkers in order to stratify which patients are going to receive a benefit from inguinal lymph node clearance and which not in prostate carcinoma. Nowadays, all prostate carcinoma cases are entered to inguinal lymph node clearance without knowing whether they actually get a clinical benefit. Now we have more stratified methods to identify these cases. And at the end, in medical oncology, what we always focus our interest is, do we get increase of overall survival? Do we get increase of time to relapse on difficult cases? Recently, we complete small studies, of course, because it's difficult to recruit, hoping to do something also with your institution, Paraboy. In colorectal carcinoma, we managed to double of the overall survival on advanced cases of disease after failure of the the recommended lines of therapy. And practically, as I said, we managed to achieve double the overall survival based on the best supportive care that these patients are receiving. And even more in pancreatic carcinoma, which the benefit actually it's 125, more than double from the standard overall survival in pancreatic carcinoma. And we move more and more to that direction by collecting data from cases or initiating pilot studies around the world in order to support more and more of the utility of these kind of assays, so that they will be implemented more to your clinical practice and help you to decide which kind of strategic decisions you're going to get from the to your routine on difficult cases. So, but what we also see is that since we have all the transcriptome available of all genome, we can use it to identify first novel targets, but as well as to do what is called repurposing. For example, we noticed that in refractory ovarian carcinoma, suddenly the red protein is highly overexpressed. So in few centers that they managed to offer that as an option to these refractory cases, we noticed that there was a clinical benefit. So practically we move forward the recommended treatment options, even to those that the guidelines has nothing to offer. But as well, we are also working on novel drug development, because all the data of all transcriptome, all phenotypes are there from multiple cases. Now we are more than 109,000 transcriptome and proteomic analytics. So we have 23 novel targets and 37 new molecules and 2 monoclonal antibodies in our pipeline. So our laboratory is not only involved in the clinical field, but as well as to the novel drug discovery and development. Because liquid biopsy is going hand by hand, helping the clinicians, but as well as creating further options for cancer cases. So what we should take home from what you have heard from the previous speaker and from me is that liquid biopsy can be used for treatment response, but with specific limits and guides. In advanced cases of disease, when the recommended guidelines have nothing to offer, they may have a prognostic value. They have, but with the condition that CTCs is, if we're talking about CTCs analysis, that we are using the proper methodology so that we will get credible data. And they are really related with how the systemic disease behaving. So this is something that we have to separate on our minds. That's why we always receive the question, oh, why the primary biopsy says this and liquid biopsy says something different or slightly or more different? Well, the reason is that obvious, the disease is not stable as we had it 2 years ago when the patient is primarily diagnosed, for God's sake. Otherwise, the disease would be easy to treat, but it's not. The heterogeneity is what makes the disease very difficult, and the adaptation to the environment that we actually create with our treatments make it even more difficult. So this is the old generation of us, of us as physicians, because an older school says I was used to memorize things. Nowadays, what we need to do is that we need to process the data instead of memorizing them, and we need to become a member of a team, of a broader team of scientists, which they need to come around us to help us. And the reason why I said that is actually this. What you can see here is the last recommendation to be implemented from ESMO. We need to have molecular tumor boards in clinical practice. That means that in difficult cases, we need to sit with other scientists and analytical methods decide based on genomic and transcriptomic and viability assays what we have to do with our patients, and assess the data and be brave to do off-label use or put patients on trials in order to generate clinical benefits for that, or even obtain data for future patients. This is it. So by this, I tried to cover multiple questions that I already had in my hands, and that was the major issues that as questions that you may have. But I'm really glad and open to hear any additional question that you may have. Thank you for hearing me. Glad to answer any questions that you may have.
Thank you, Dr. Yunis, for that discussion on the clinical relevance of the circulating tumor cells. I think there are some questions from the audience.
Yes.
Hello?
Yeah. I am Samuel Haryono from Dharma East Cancer Hospital.
Yeah, I can hear you loud and
okay.
clear.
Yeah, can you hear me?
Yes, loud and clear.
Okay. As I have learned with your presentation, I find something there in my mind about the ctDNA. Well, I think ctDNA is using the DNA, using the circular tumor, the fragment of DNA, and showing how that we can detect and how to know. But you said that with the CTC, there are lots of you can learn about the behavior. But I'm quite wonder about the platforms that you use. And you have already mentioned there are flow cytometry and ACGH, array comparative genomic hybridization, and so forth. Well, what I'm asking is, first, in the caricature that you showed the presentation, the CTC is only the cell, not included inside the nucleus. This is the first of my question. And how can, a second question, you said that selecting the cells, how to know the behavior. Can you tell me about how can you know the behavior, which is more on the metastatic side? And can you tell me a little bit details so that we can differentiate the superiority of the CTC comparing with the ctDNA? Thank you.
Of course. Well, superiority. It's not superiority. It's about the population of CTCs is relative, not relative. It's small. So in order to do analytical assays, because it's not only the ACGH, as the previous speaker said, after the negative selections and the isolation of cells, then cells are entering to collagen hydrogels in order to have an orthotopic model of how the cells are behaving inside the body. And this is where the tumoroids are forming, because the cells are starting forming tumoroids, entering on exponential phase of growth afterwards, so that you will get the population of interest. And then these cells are entering for transcriptomic analysis, which means all genome expression. And another part is entering for microcolonies assays of viability with Alamar Blue. So practically you do have all the behavior of the cells after exposure to medication, and as well as you have all the genome expression, the mRNA levels of all these cells. Practically, you could see which targets do expressed on higher level, because the transcriptome is closer to proteomics. We must not forget that our drugs doesn't target DNA, they are targeting proteins. And whether we have found a DNA doesn't mean that the protein is expressed. This is something that we have to understand. So transcriptome give us one step closer to the proteomics, and the viability assays confirm the linearity of your transcriptomics. This is what gives you the advantage because you have multi-layer of analytics. You have your CTCs as present, you have your transcriptome of all genome of your CTCs, and as well as you have the behavior of the cells after exposure to the active form of a drug in a microcolony.
Thank you. May I just one more questions about the time limit? Yeah. There is a turnaround time for the sampling to get to be into the lab. And as I know, the ctDNA is using the exosome to differentiate between necrosis, apoptosis, and programmed cell death. So how long? Is it longer, or how much time it takes to get to the lab?
Well, practically, this is the reason why the vial of collection includes a preservative liquid, because we have to say that you cannot rely on a simple, let's say, EDTA, etc., only on your vial, so that the cells will stay intact and they will not die, or they are not forming clumps. There are preservative liquids with a protein and other combinations inside, so that the cells will remain intact and doesn't go on further steps or die at the end. They could stay, we have done validation that they could stay even in ambient conditions up to 4 to 5 days. And in cooling condition between 4 to 8 degrees, they could reach up to 12. So the time of fly in worst case scenario is between 3 to 4 days, worst case. After that, when the sample arrives, it passes quality control, so that we will see that nothing has been altered, and we monitor also the time of flight. Because, yeah, the companies may tell you, yes, we have the best conditions, but you have to confirm that, yes, they do fulfill the requirements. And as long as the sample is intact, we do the analytics. The validation process resembles exactly that. We took a sample in one, then we split it in two, then we did analytics after 4 days, representing the time of fly, and we did the analysis on an immediate sampling. And we noticed that exactly after preservation liquid, between 4 to 5 days in ambient condition, we get it's almost identical fingerprinting. And in 4 to 8 degrees, we could reach up to 12 days.
Thank you.
Most welcome. All of what I've said exists as studies in our literature. So if you go in our original website, you are going to find the validation of these blood sampling transport between ambient condition and cooling conditions, stability of it. This is all validation is we try to put it out to the world, make it publicly available.
Yeah. Hello.
Yeah.
Yeah. Yeah. My name is Muhaimin from Darmais Cancer Center, Jakarta. Yeah. I have some questions actually. Maybe if I can help someone to help writing down the questions, because I will just ask all the questions. No, I have more than 5 questions actually.
Dr. Muhaimin, we can help.
Okay. My first question is, maybe it's a very basic question. The CTC's detection is based on surface markers, is it? Like you use the surface markers as the target of your antibody? No.
No.
So how
so the first step is start your interrogation with site scattering high, because you expect that your circulated tumor cells have higher granularity compared to your blood origin cells.
Okay.
And then all of them, they are CD45 negative. That's why you are starting with negative selection.
Okay.
So, and this is very well defined. We always expect that the metastatic population, especially on solid tumors, they are on the metastatic gate. And then you have to subtract all the unwanted cells, which means platelets, a lot of endothelial cells on pericytes, because none of the blood sample is perfect. And then your cells are there. So as long as you subtract them, then your population is there. If you want to immunophenotype them afterwards in order to do tests like OncoTrace, then yes, you on the metastatic population, you do analytics on biomarkers on their surface, but only for immunotyping them, not to separate them. You separate all the metastatic gate.
Okay. So my second question is the detection of CTCs in early stage cancer. For example, you have a case where you detect the presence of the CTCs in the circulation, but there is no clinical or radiological evidence of established cancer. Okay, so in these conditions, what is the policy? What would you do?
The policy is, well, let's change hats now. From scientist, I have to speak like a medical oncologist right now. Unless I will have a diagnosis of cancer, let's say macroscopically, I cannot treat aggressively the tumor, despite of what I see as a circulated tumor cells. The reason is, if I try to treat a patient in that stage, probably I may give more toxicities than clinical benefit, because none of our medications are lacking of toxicities. So the only thing that I can do is to follow up the patient and simply expect from where this dissemination is taking place. So the policy is we could do methodologies like ACGH, find out from where they are coming from, and screening the patient in order to confirm the presence of macroscopic disease in the future. Because we had few cases like this, and literally in the future they did develop the macroscopic disease as expected.
Even if the detection level is quite high, I mean, like the CTC's volume in the blood is very high, for example, it doesn't justify to start any treatment.
Correct, because in order to prove that there is a clinical benefit, it requires, based on statistic, a clinical trial of multicentric, which should recruit at least 16,000 positive cases. As you can understand, this is by far not realistic to happen.
Okay. Still have some more questions. Any established criteria for patients' eligibility or screening by CTC section?
Well, we know very well that primary brain tumors cannot be detected simply because they are not spreading tumors to the periphery. So glioblastomas, for example, we haven't seen circulated tumor cells on the periphery. We may have a chance to detect them on a cerebrospinal fluid, but only on 50% of the cases. So yeah, this is one criteria that you cannot work with liquid biopsy on primary brain tumors, because probably the blood-brain.
Okay. Yeah. Can I ask my next question? Yeah. Do you have cases where hello?
I think Ioni's network dropped. We have to wait for him to come back again.
Okay.
So meanwhile, while we are waiting for Dr. Ionis, so we can introduce, let the MC from Paraboy introduce the panelists of our sessions.
Okay, thank you, Dr. Lola, and our speaker for valuable insight. Everyone, we are now moving into the Q&A discussion session moderated by Dr. Concertius Lola. If you have questions, please feel free to type them in the chat box. Our panelists for the Q&A and discussion are Dr. Sonar Sonipanikoro, Surgical Oncologist, Magister of Epidemiology, March, PhD, Dr. Derajat R. Suwardi, a Surgical Oncologist, Dr. Samuel J. Haryono, Surgical Oncologist, PhD, Dr. Manti Prisodewo Sumitro, Surgical Oncologist, Master of Health Science, Mars, Profesor Dr. Prihantono, Surgical Oncologist, PhD, Profesor Dr. Putuanda Tusta Adiputra, Surgical Oncologist, PhD. And for the last, Dr. Muhaimin Hussein, Surgical Oncologist, Master of Science, Master of Public Health. Let's begin the discussion. Dr. Lola, the time is yours.
Okay, so
Yeah, we are still waiting for Dr. Ionis.
is there any case sharing from our panelists or any questions from our panelists?
Yeah, I do actually still have some questions, but I think we are still waiting for Dr. Ionis to join the meeting again. Oh, Dr. Walter is raising his hand. Maybe we can go to Dr. Walter first.
Thank you, Dr. Muhaimin. I want to ask about the clinical application of the CTC test. If we have the result of immunochemistry from tissue biopsy for breast cancer case example, the tissue biopsy immunochemistry result is triple negative, and then we do the CTC test and the result is luminal type. Which one you choose to plan the treatment for the patient? I asked for Ionis and Dr. Lola.
Now I just joined. Can you please repeat the question?
Yeah. I want to ask about the clinical application of the CTC test when we have the result of tissue biopsy and the immunohistochemia result is, as example, triple negative breast cancer. And the CTC result is luminal type breast cancer. Which result you choose to plan to treat the patient?
Well, Dr. Lola, do you want to contribute or?
Okay, doctor. So for that case, the immunochemistry is primarily done on the tissue, whereas the CTC was being done on the for the cancer cells that have been shed to the circulation. So there will be really some discordance with regards to the primary and the metastatic site. So it is possible that the primary would be triple negative, but the metastatic one will already be hormonal positive. I think both should be addressed because if you only address one, for example, we only address the primary site, it's only the primary site that will respond, and the metastatic site will not respond to that particular treatment. So if there is targeted therapy or a targeted molecule that we could give in addition to chemotherapy, I think that's the way that we should treat that patient, as much as possible, addressing all the possible targets that we could get. Dr. Yonis, you have an addition?
Well, actually, you place it really correct, because if you rely only on the primary side, you're going to lose the population which are driven by let's say, estrogen receptors. So practically, you are treating only the primary side, and you are leaving the metastatic population to develop a recurrence. So yes, we have to overlap the two. This is what Dr. Lola is actually trying to say, and this is what it's let's say, wise to do in order to increase the chances to gain a response on a systemic level, not only to the primary side.
Thank you, Dr. Yunis. Any additional questions from our panelists? Or
may I continue with my questions? Because
yes, please, because
Dr. Ionis was not
my
here
laptop
before.
was collapsing. I apologize for that. So
Yeah.
I'm joining from my mobile phone now.
Yeah, it's completely fine. Okay, so my next question is, do you have any cases where the tumor is clinically or radiologically clearly detected, radiologically or clinically, but you fail to detect CTC in the circulation? Is there, I mean, have you found cases like this?
Yes, there are. As I said, there is no perfect world out there. So we cannot, I would be really a liar if I said that the test is covering everything and every case. Yes, there are. Actually, these are the cases which actually represent the 13%. But we know exactly why these cells are missed. Unfortunately, we haven't specified yet based on the type of cancer or what are the conditions, but we know what is actually happening.
Okay.
So far, we know that circulated tumor cells are only the disseminated cells that they are moving from the primary tumor. Well, the story doesn't stop there. There are chances on types of cancer which the circulated tumor cells can be fused with monocytes, and they create a kind of hybrid cells, which so far we have no biomarkers and no way to identify them. Unfortunately, these cases are really aggressive because also you could find the relevant literature about that. These fused cells are at least 10 times more aggressive than the original primary tumor and the original CTCs, and they become highly metastatic.
Okay.
Most of the cases that we do have these types of tumors and there are no CTCs detected, most of the cases are cases like that. And these cases, unfortunately, we haven't found it. There was a promising biomarker, but unfortunately, it had been failed to prove the value. It's called 168, CD168, but it didn't work well in actual clinical cases, so I cannot bring it to actual patients yet. So we're still struggling how to identify this hybrid type of cells that are happening in these cases.
Okay.
I have to be honest to you, this is what we have seen.
Okay, so do we have any like known clinical conditions where we can expect that the CTC test will be the result of CTC test will be negative? I mean, like So we know prior to the test that the patients are not candidate for the test.
Well,
Like-
as I said, we haven't specified exactly the types because, as it seems, probably it has to do with the types and mainly with the differentiation. But we haven't specified it yet. We do have guidelines of how the patients should be prepared, what are the conditions so that the patients will proceed on sampling for CTCs. But catching up these cases of not finding CTCs where the tumor is there, we haven't been conclusive to that.
Okay. Yeah.
I don't like to put guidelines out of the blue, really. I want to put credible data after validation.
Okay. Yeah, it's still a long way to get there. My next question is these CTCs, are they like how to say like a homogeneous population of cells, or there's also heterogeneity with the CTCs? I mean, you are not talking about one type of cells, but there are also subsets of. Yeah.
You have absolutely right. It's heterogenic population as well, but they have one tremendous advantage. At the end, what we are trying to find is the what we call cancer stem cell-like, the cells that they have tumor-initiating properties, that they can regrow a tumor as long as they are engrafted in a distant organ. The major difference is the following. If we try to identify this tiny number of cells, which exist in every solid tumor, metastatic or primary, they represent a very, very, very small population. Practically, it's impossible to find them. But in CTCs, they represent 60% or above of this population. This is what makes them very viable. Not the CTCs as they are, but the subset that they represent the cancer stem cell-like. And the proportion of CSCs, of cancer stem cell-like, on CTCs is maximum, 60% and above
of the
total CTCs.
So there's a subset of the CTCs that have more clinical significance. Yeah.
Correct.
Yeah.
They called tumor-initiating cells. This is the correct name. But nowadays, in our talking language, we call them cancer stem cell-like because they behave similarly, but they are not coming from stem cells.
Okay. So my last question, to have the result of this anti-cancer sensitivity, you do cell culture, or how do you do it?
Well, it's not a culture as you know it. We are using tumoroids and organoids co-culture with other cells, because if we want to, for example, to assess the immunotherapy, you need to do co-culturing. And this is happening in hydrogels, as I said, with the presence of collagen, so that you will have an orthotopic model exactly how they are growing inside the human body. Because there are other hydrogels which are completely synthetic, but they are by far not representing the human body.
Will you end up getting like a new cell line, or?
It's not cell line. We try to keep the heterogeneity as much as we can, and there is no clonality. This is the difference between 3D culturing and 2D culturing. And this difference actually makes the significant impact in the clinical practice. The 3D culturing is way closer to clinical reality compared to 2D culturing in a flask or in a dish, which it's very easier to handle, but you do have a clonality. Practically, you're selecting one clone of the many that you have, and they don't represent anymore after a few generations the actual original sample and the clinical status of the patient.
Okay. So you will have like how to say, like a bank of living cancer cells in your lab after all these tests,
as I
right?
mentioned, 109,000 cases on actual biobanking.
Okay. So what what do you do with all of this, like all of this
Well, practically, this is the work
treasure?
that happens in the back scene. We anonymize them and we find repeatable patterns on the same type of cancer in the same condition in the same stage, and try to find a novel target, a possible protein which so far we haven't put them on drug discovery, and we, based on how this protein is, where it's located, what is its functionality, we decide whether we're going to develop a novel drug, small molecule, or a monoclonal antibody, or a cellular therapy.
So they are all assigned
This is
to
the
a
back
further
scene.
test, yeah?
Yes, yes.
Okay.
So that's why I said liquid biopsy goes hand by hand with clinical utility as well as drug discovery.
Mhm. Okay, thank you so much, Dr. Ioannis. I think that's all my questions for now.
Practically, you are helping not only the patient of today or the patient that you have in front of you, but the future patients of that they're coming.
Yeah, that's the future of this test.
Yeah, correct.
Yeah. Okay, thank you for all the
Most
answers,
welcome.
Dr. Ioannis. Yeah.
Thank you, Doctor. In as much as we want to accommodate all the questions, but due to limited time, we only left with 2 questions more, one from Dr. Sonar and one from Dr. Maulina. Probably we could start with Dr. Sonar. So the question is, why is the CTC cutoff different from each type of cancer? And why do some sample results show CTC values that do not match the clinical progression? I think that's the
Well,
question.
yes, of course. Well, not all types of cancer disseminate in the same rate. For example, we know that prostate carcinoma is disseminating way faster and way more compared to, let's say, to sarcoma types, soft tissue sarcoma types. So that is the first. But even though what is more clinical relevant is not the rate of dissemination than the actual change and shift of the phenotype of the cell. For example, even before the dissemination, when or before the risk of migrate to a distant organ, create a novel metastasis or create a resistant phenotype, the cells always adapt to the environment. They are adapting the protein profile. So in order to become metastatic, they need to become more flexible. So they need to dissociate the cytoskeleton, as we say. So this first step requires the presence of specific receptors. So c-Met is one of them, and a very critical one. So there's no need to start seeing the large number of dissemination when the phenotype is already coming first. So this is the reason why we always insist the phenotype always prevail to the number of CTCs. Being alert when the phenotype is changing and shifting. Another example is that when the tumor becomes more resistant, it develops stemness properties. So if SOX2, OC3, 4 coexist, means that the tumor start becoming quiescent or develop stemness properties. So they become more aggressive. So this is happening way earlier than the increase of number of CTCs to the periphery. So we need to, again, to monitor all these changes on the phenotype, simply because they are driving. They are the first step of every functional process of the cells.
Thank you, Doctor. So probably for our last question from Dr. Maulina.
Okay.
So question is, thank you, Dr. Sarah, for your interesting presentation. Can you show the microscopic non-illustrative appearance of CTC of breast cancer patients or other solid tumor. Sometimes advanced stage patients show thrombocytosis, leukocytosis more than 20,000 or elevated D-dimer. Are those actually CTCs? Can CTC be seen in the peripheral blood smear?
It's very rare. You will be very lucky if you find them, but what you can find is actually on advanced cases of disease, you can find the clump that they could form. Usually there is a stage when they become very advanced, which the disseminated circulated tumor cells actually interact with platelets, and they form a kind of clump around, which they call microemboli. And this is what it has been detected from primarily from Christie Hospital in the UK. I believe it is the location. It's actually in Livermore, in Manchester. Sorry. And this is how they have been characterized, but only in very advanced stage of the disease when actually there was an activation of platelets. It was the presence of clot, as you to describe it. But this is happening only in advanced cases of disease, not in early stage, or when the patient is in normal condition. Nowadays in medical oncology, we always, let's say, we do prophylactic treatment on our patients, and we are avoiding these kind of conditions of taking place already. But in older times, yeah, it was very common, and this is how actually this hospital can find that, whoa, I have microemboli, and suddenly they realize that there was a tumor-originated cell inside the clump.
Thank you, Dr. Yunis. Probably the last question. So we have from Dr. Monty.
Okay, thank you, all speakers. Good morning. I'd like to ask Dr. Yunis. My attention is more to the early stage of cancer. Do you think that CTC can help us to make a prediction of metastatic or recurrency after we do surgery? Thank you.
It can, but with specific conditions. There was a study that took place in Germany, in the University of Bayreuth, but it shows that after surgery, for the first 4 weeks, there is a massive dissemination of cells, which not all of them are actually normal CTCs, simply because you are excise the tumor, you induce dissemination. It's not a normal process. So practically you see a wave of large number of disseminated originated cells, but after 3 to 4 weeks, this number is dropping down. If you do the sampling after this period of flare, yes, your CTCs that may remain do have a clinical value. If you do that immediately after surgery, you get a lot of noise, debris cells, which have no clinical value. This is a critical condition to happen. I can send you the study if you want to, because it was very thorough. They explore exactly that.
Okay, thank you, Dr. Yunis. Thank you.
Most
welcome. Thank you, Dr. Monty. So I think that's our last question. May we call out again our MC to wrap up our event?
Okay, so for the questions, I think we can divert to the question collection form. For the question collection form is shown in the Q&A sessions and the comment sessions. So we can use this Google form to submit your questions. And from our side, we'll answer the questions. So it's a very good sessions, and we very thank you, Dr. Ionis, Dr. Sarah, and Dr. Lola, and for the panelists of these sessions for a wonderful sessions. So right now we can also pass the time to Dr. Draven from RGCC SEA, and for the final wrap up of these wonderful sessions. Thank you very much.
Thank you, all of you, Paraboy members and Cinemas, Dr. Welta and Ionis, all of our Southeast Asia team. Thank you for being part of today's inspiring webinar. And there's a few things that's very important. We are very honored to collaborate with Paraboy on the joint research study for all of you for your information. The title of the study is Clinical Applications of CTC Profiles to Monitor Pathological Responses and Distant Metastasis-Free Survival in Breast Cancer Undergoing Neoadjuvant Chemotherapy. Why is this important? Because this partnership represents a significant step forward in precision oncology. So I also like to express our deep gratitude to Cinemas, our trusted partner, exclusive distributor in Indonesia, for their steadfast support in bringing RGCC diagnostics and therapeutics and Ionis treatment framework to clinicians in Indonesia. To all attending doctors, we really invite you, if you can see from the chat, to register for the RGCC doctor portal. And those who sign up today will have access to the clinical tools and will be invited to join our molecular tumor board led by Dr. Lola, who is using, we term it as OncoPro, the framework of treatment developed by Dr. Ionis to integrate RGCC test data into practical oncological decisions. Once again, thank you so much, all of you, for your presence, partnerships, and commitment to excellence. Together, we are building a future where cancer care is deeply personalized, evidence-driven, and collaborative. Thank you so much. That's my message. Thank you.
Thank you, Dr. Lola, for being the moderator and also for our speaker and panelists on this session. Before we officially close the session, we would like to kindly ask all speaker, panelists, moderator, and participant to turn on your camera for a group photo. Please make sure your video is on and smile at the camera. We will take a few screenshots in 3, 2, 1. Another slide. One more time, just to be sure. Make sure your video is on and smile at the camera. 3, 2, 1. Okay, thank you for your participation, ladies and gentlemen. That concludes today's session. On behalf of the organizing committee, we certainly thank you for your participation and attention. We hope today's insight will be valuable in supporting clinical application and cancer care improvement in Indonesia. As a reminder, this webinar is eligible for SKP accreditation from the Ministry of Health. Please visit the Pelataran Sehat platform to claim your SKP points. See you again in the next event. Wassalamualaikum warahmatullahi wabarakatuh. Good afternoon and thank you.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you. Bye-bye. Thank you.
I'm here just to raise the level of what RGCC stands for and what is the actual purpose of all group of laboratories and companies on serving cancer patients. We try first to help cancer patients and doctors at the present time, and we try also to help cancer patients in the future. That means we are offering testing and screening for cancer patients in order to have tailor-made therapies. And as well, we are working intensively in the back end on drug development and discovery in order to develop novel therapeutic approach for cancer patients in the future.
Untuk pasien kanker, seiring waktu dipenuhi rasa takut dan ketidakpastian. Bahkan setelah memulai pengobatan, beragam pertanyaan tetap ada. Apakah terapi ini berhasil? Apakah kanker sudah menyebar? Apakah kanker benar-benar terkendali? Terkadang pemeriksaan dan tes rutin gagal mendeteksi bahwa kanker masih ada atau pengobatannya belum maksimal, menyebabkan pasien dan keluarga tetap berada dalam kekhawatiran dan tidak dapat melihat situasi dengan jelas. Sekarang, bayangkan sebuah masa depan di mana Anda tidak perlu menunggu dengan rasa takut, bertanya-tanya apakah pengobatan kanker Anda berhasil. Dan dengan tes darah sederhana, Anda memiliki kesempatan untuk melihat tidak hanya jumlah sel kanker di tubuh Anda, tetapi apakah sel-sel itu masih menjadi ancaman. Memperkenalkan OncoTrace, tes revolusioner kami, yang membantu mengatasi tantangan ini secara presisi dan personal, menyediakan kejelasan kepada pasien dan dokter untuk membuat keputusan. Kanker dimulai di sel-sel kita. Ketika sel sehat bermutasi atau rusak, mereka berkembang biak terlalu cepat dan membentuk benjolan yang dikenal sebagai tumor. Seiring perkembangan penyakit, beberapa sel terlepas dari tumor dan masuk ke aliran darah menjadi sel tumor yang bersirkulasi atau circulating tumor cells. Jumlah CTC menggambarkan sel kanker yang beredar dalam darah, adalah indikator penting dari progres pengobatan kanker. Namun, untuk benar-benar memahami situasinya, penting untuk melihat lebih dari sekedar angka. OncoTrace meningkatkan pemahaman ini dengan menganalisis tidak hanya kuantitas sel kanker, tetapi juga karakteristik spesifik melalui penanda fenotype dan penanda stemness. Menawarkan pandangan yang lebih komprehensif dan personal, tes ini memberikan informasi berikut: jumlah CTC, penanda fenotype, penanda stemness untuk membantu klinisi membuat keputusan. Jumlah CTC, ini adalah ukuran jumlah konsentrasi sel kanker yang beredar dalam tubuh. Peningkatan konsentrasi CTC mungkin menunjukkan bahwa pengobatan tidak sepenuhnya efektif.
Hello, my name is Dr. Ioannis Papasoteriou. I am the director of our GCC group of companies and laboratories. I'm here just to raise the level of what our GCC stands for and what is the actual purpose of all group of laboratories and companies on serving cancer patients. We try first to help cancer patients and doctors at the present time, and we try also to help cancer patients in the future. That means we are offering testing and screening for cancer patients in order to have tailor-made therapies, and as well we are working intensively in the back end on drug development and discovery in order to develop novel therapeutic approach for cancer patients in the future.
Untuk pasien kanker, seiring waktu dipenuhi rasa takut dan ketidakpastian. Bahkan setelah memulai pengobatan, beragam pertanyaan tetap ada. Apakah terapi ini berhasil? Apakah kanker sudah menyebar? Apakah kanker benar-benar terkendali? Terkadang pemeriksaan dan tes rutin gagal mendeteksi bahwa kanker masih ada atau pengobatannya belum maksimal, menyebabkan pasien dan keluarga tetap berada dalam kekhawatiran dan tidak dapat melihat situasi dengan jelas. Sekarang, bayangkan sebuah masa depan di mana Anda tidak perlu menunggu dengan rasa takut, bertanya-tanya apakah pengobatan kanker Anda berhasil. Dan dengan tes darah sederhana, Anda memiliki kesempatan untuk melihat tidak hanya jumlah sel kanker di tubuh Anda, tetapi apakah sel-sel itu masih menjadi ancaman. Memperkenalkan OncoTrace, tes revolusioner kami, yang membantu mengatasi tantangan ini secara presisi dan personal, menyediakan kejelasan kepada pasien dan dokter untuk membuat keputusan. Kanker dimulai di sel-sel kita. Ketika sel sehat bermutasi atau rusak, mereka berkembang biak terlalu cepat dan membentuk benjolan yang dikenal sebagai tumor. Seiring perkembangan penyakit, beberapa sel terlepas dari tumor dan masuk ke aliran darah menjadi sel tumor yang bersirkulasi atau circulating tumor cells. Jumlah CTC menggambarkan sel kanker yang beredar dalam darah, adalah indikator penting dari progres pengobatan kanker. Namun, untuk benar-benar memahami situasinya, penting untuk melihat lebih dari sekedar angka. OncoTrace meningkatkan pemahaman ini dengan menganalisis tidak hanya kuantitas sel kanker, tetapi juga karakteristik spesifik melalui penanda fenotype dan penanda stemness. Menawarkan pandangan yang lebih komprehensif dan personal, tes ini memberikan informasi berikut: jumlah CTC, penanda fenotype, penanda stemness untuk membantu klinisi membuat keputusan. Jumlah CTC, ini adalah ukuran jumlah konsentrasi sel kanker yang beredar dalam tubuh. Peningkatan konsentrasi CTC mungkin menunjukkan bahwa pengobatan tidak sepenuhnya efektif, sementara penurunan dapat mengindikasikan keberhasilan. Penanda fenotype, penanda-penanda ini mengungkapkan sifat-sifat melalui protein pada permukaan sel. Penanda ini membantu menentukan asal kanker, karakteristiknya, dan bagaimana kanker tersebut dapat berperilaku. Informasi penting ini sangat membantu dalam menangani kasus kompleks yang melibatkan beberapa tumor atau metastasis. Penanda stemness adalah protein yang menunjukkan sifat seperti sel punca pada sel kanker. Penanda ini mengungkapkan seberapa agresif kanker itu, serta kemungkinan kanker untuk tumbuh, menyebar, atau kambuh. Tingkat presisi tes ini memungkinkan penanganan Anda tetap selangkah lebih maju dari penyakit ini. Tanpa analisis terperinci, keputusan mungkin diambil berdasarkan informasi yang tidak lengkap yang berpotensi menghambat pemulihan. OncoTrace melengkapi informasi dan menawarkan pandangan yang komprehensif dan personal tentang kondisi kanker. Ketika Anda memahami kanker Anda lebih dalam, Anda tidak hanya menebak. Anda membuat pilihan berdasarkan informasi yang dipandu oleh data penyakit Anda secara khusus, sehingga dapat memantau perkembangan penyakit untuk mengatasinya. Dengan OncoTrace, Anda tidak hanya melacak kanker Anda membuka jalan menuju pemulihan secara presisi dan personal. Pilih RGCC untuk solusi kanker yang presisi dan personal.